Thank you, Chairman. Guten Tag. As time passes, I feel more like a family member in this great meeting. Thanks to last year's great meeting in Florence, I had a great opportunity to join the precise MI study. Principal investigator is Christian Weller. Working on patient enrollment, I thought it is useful to share some tricky cases from our actual precise MI cohort. Today, I prepared 3 cases. We are all familiar with this 2020 ESC diagnostic algorithm in acute coronary syndrome. First, no indicator, right? This one? This one. Oh, sorry. Oh. Clinical, second ECG, third troponin level at 0 hour and change. Our Seoul Center recently adopted ESC01 algorithm for high sensitivity troponin I. We use a Siemens kit. So we consider greater than equal to 120 picogram per milliliter significantly high. Let me start the first case. A 56-year-old man visited our emergency department with chest pain. The chest pain was intermittent, started the day before, and current episode lasting about 30 minutes. His past medical history included hypertension and diabetes. He smokes currently. This is the first ED arrival ECG. What do you think? Anyone? Sure. Look at this. So the ED doctors make an emergency STEMI activation, and they call the cardiologist for the primary intervention. Regardless of the high sensitivity troponin I result. The first troponin I level was very, very low, but within 30 minutes, we did the emergency coronary angio. As you can see here, only intermediate stenosis at RAD, so no percutaneous coronary intervention. Yeah, let's review the serial ECGs. 4 months ago, his ECG was like that, so only early repolarization pattern, but normal. At ED arrival, I think it is a significant ST segment elevation in interceptor leads. And after CAG, and the next day discharge. So there is no typical ST segment elevation MI changes. Also, after CAG, second troponin very low, and the next day discharge with low troponin level. So what is your impression? Actually, this was a transient elevation of ST segment without actual myocardial injury or infarction. But they called cardiologist. Let me move on the second case. A 71-year-old man came to our emergency department via 911 with chest pain. Chest pain onset was 2 hours ago, squeezing, burning, and resting pain. Sublingual nitroglycerin had no effect. His past medical history included hypertension, diabetes, paroxysmal atrial fibrillation, and percutaneous coronary interventions. 2018, STEMI, he had 2 stents at CIRC and LAD. 2019, non-STEMI, no ISR, so only medical treatment. This is the ED arrival ECG. Any idea? Yeah, slightly ST segment depression here, we thought. Here are the first and second troponin levels. Actually not that high, and also the increase was only 0.2. So we followed. So surprisingly, actually, there was no significantly high levels until 5.5 hours. Then the ED doctors called non-STEMI. We reviewed the ECGs. 7 months ago, the ECG was completely normal, and at the time of ED arrival, slightly ST segment depression. 3 hours later, prominent ST segment depression, mostly anterolateral leads. This is his coronary angiogram. As you can see here, LAD stent patent, but SOC ISR with thrombus. So we did a drug-eluting balloon procedures. Here is the serial troponin changes from the ED entrance to the hospital discharge. 1 week later, outpatient clinic, the ECG was completely returned to normal. So with high sensitivity troponin ISA, most patients can be diagnosed within 2 to 3 hours of presentation. But just like this case, if it is negative, even though it is negative, there is a high degree of suspicion of acute coronary syndrome. We have to do more longer serial troponin testing. Yeah, I will go on the last case. During the study period, we have some patients are frequently visited our emergency department with chest pain. This patient was the second most frequent visitor in our Seoul center, total 15 times. So I want to share this case, especially the latest episode. This 51-year-old man came to our emergency department via 911 with chest pain. The chest pain was significant. For 1 hour, continue and squeezing, burning, resting. His past medical history was complicated with panic disorder and multiple coronary angiography with spasm, but no fixed lesion. Here is the ED arrival ECG. What do you think? For me, it looks normal. So here are the first and second troponin levels. As you can see here, it was low, and the increase is not significant after 1 hour. What should we do? Actually, follow-up 3.5 hours, the troponin increased. And also, if we follow the ECG, I think ECG follow-up is important. Just a single normal cannot rule out the acute coronary syndrome. 1 hour later was still normal, but after 2 hours, we see ST segment elevation in inferior leads, which was normalized after nitroglycerin. What is your impression? So here is the troponin chart. Actually, he discharged with more vasodilator medication without coronary angiogram this time. Let's review the previous coronary angios. 2014, coronary angiogram shows a very, very, very slow coronary flow. 2018, we decided to do the provocation test. So we used the intracoronary ergonovin. As you can see here, there is a significant spasm developed. And also, which is reversed after intracoronary nitroglycerin injection. So it is proved vasospasm. And then 2021, another episode of chest pain. And this time, RCA looks okay, but LAD diffusely spastic narrowing. So what we did is, as you expected, we did give intracoronary nitroglycerin, and it reversed very well. So it was a reversible spasm of coronary arteries, resulting in transient myocardial ischemia. More prevalent in Asia. Yeah, I think so. We have much, much more spasm. So it can be a cause of frequent ED visit, like this patient, especially combined with some psychiatric issues. Yeah, let me summarize. Especially like tricky cases, we in the diagnosis algorithm should have a complemented by prior medical record and ECG comparison, not the single changes, and also serial pattern of troponin, sometimes with longer follow-up, even if it is negative. If a clinically high suspicion, we should do longer follow-up. It reminds me the Albert Einstein's word, learn from yesterday, live for today, hope for tomorrow. The important thing is not to stop questioning. Thank you for your attention.
Thank you for this thought-provoking talk. Are there questions from the audience?
So if I may, thank you very much for showing these really tricky cases. And I think even though we know that the ESC 1-hour algorithm is very helpful in the vast majority, there might be such, there are such tricky cases where we also always need to have the right to overrule the recommendations by the algorithm. I have two questions maybe. Were most of these patients still at strong pain at the time that you have seen them at the ED? Mm-hmm. And the second question would be, in the first patient with a dynamic ST elevation in the ECG without any troponin dynamics,
yes.
Did you perform some imaging, MRI or echo that indicated some signs of pericarditis?
Oh yeah, good questions. The first one, if it is just like a vasospasm, it surely comes and goes, so not consistently for 1 hour. And also if we try to nitroglycerin sublingual, most of the case, if it is not strongly delayed, it is reversed nicely. So the pain is not always continuous pain. And the second one, actually the first case, it was really tricky. The ED resident make a call, but they are so sorry for the cardiologist after that. But there was no evidence. We did echo, but no MRI, but there was no such a myocardial injury evidence. And even though there is a myocarditis, we can see some kind of a little changes of troponin. So that case was a very questionable and tricky.
Christian.
So thank you for sharing your wonderful cases. In one of the cases, or repetitive ECG was very, very helpful.
Yeah.
Can you share what is the protocol that you have? You do a second ECG only in patients who have another chest pain episode, or in patients whom there's still uncertainty, or do you do a second ECG, for example, after 1 hour in all patients? What's your strategy?
That is a great question. Actually, we have a policy or protocol in terms of high sensitivity troponin follow-up, but there is no strong protocol when should we follow, mostly based on the clinician's judgment nowadays. But if we have more study of a follow-up ECG, we may have some idea when should we follow. And the second, this is not another episode. Sometimes you are suspicious, we are just following, even though there is no strong another new episode. So when I uploaded the data, I thought just a single ECG, the initial data, cannot tell everything. I saw the next one and next one, but the data included is just one. So sometimes it's normal, even though it is ACS. So we may have some idea of a follow-up ECG and it reflect the changes, not the first ECG from the arrival. Thank you.